Hello there, everyone. So we're just, touching the 6 o'clock mark. I can see there's about 100, I think, participants who've managed to join us at this time, and hopefully more people will join us later. My name is Anita, and I'm actually from Malaysia. I'm a clinical oncologist based in the Faculty of Medicine, University of Malaya in Kuala Lumpur. And I'll be the moderator for this evening's session because my colleague, Marniza, who was actually supposed to do this session, unfortunately, she's been deployed to look after one of the COVID wards. So she's not able to attend this session today, but she sends her warm regards and wishing all of us, hopefully we'll have a good session, this evening. Now, before I go on to introduce our distinguished speaker and panelists for today's webinar, I'd like to invite Dr. Azrif, who is the president of the Malaysian Oncological Society, to give us a short, welcoming speech remarks. Please, Azrif, over to you.
Thank you very much, Anita. Good evening, everyone. I am Dr. Azrif Anwar, President of the Malaysian Oncological Society, and it gives me great pleasure to welcome all of you to this 8th Federation of Asian Organizations for Radiation Oncology webinar. It is indeed an honor for MOS to host this webinar on value-based medicine in radiotherapy. I would like to express our special thanks to Professor Anita for being the moderator, Dr. Paul Corns as a speaker for this webinar, and also Professor Fuad Ismail from Malaysia, Professor Gholam Farouk from Bangladesh, and Professor Suhartati from Indonesia as a panelist. I hope you all have an interesting webinar and a stimulating panel discussion. Thank you very much.
Thank you very much, Azrif. Now, as Dr. Azrif mentioned just now, today's webinar, this is actually the eighth Faro webinar for our series for this year on value-based medicine in radiotherapy. I would first like to introduce our speaker, and we have 3 distinguished panelists for this session. Now, Dr. Paul Corns, say hi, Paul. Hi, Paul. Now, and Paul is actually no stranger, well, at least to me anyway, because I've known him for quite some years now. He's been very helpful as an advisor, external examiner for our training program in Malaysia. Anyway, Paul is actually from Bristol. He's a clinical oncologist at the Bristol Hematology and Oncology Center. And he's been part of the steering group for the European School of Oncology Working Party on the access to innovation in cancer treatment. So he encourages physicians that health economics is to be embraced as part of routine medical practice. And Paul teaches that we have to move forward with evidence-based medicine to adopt value-based medicine if innovation is to be affordable. And he's been involved in teaching courses on cost-effective care in countries like, in fact, he's been to Malaysia a few times in collaboration with our Minister of Health, trying to come up with ways as to how to make cancer treatment more affordable and more cost-effective, if you like. So that's Paul. Now I will go on to just introduce our 3 panelists. Now the first one is actually Fuad Ismail. Say hi, Fuad. Okay. Now, Fuad is actually, again, no stranger to me because I'm married to Fuad Ismail. So in any case, Fuad is the head of department at the UKM Medical Center, Radiotherapy Oncology Department. He is probably, and is, I think, the most senior oncologist in the public sector. I believe so. So, yes. And Fuad, again, has been very involved with value-based medicine courses and workshops together with Paul. And Fuad's been involved with, the cancer blueprint projects in Malaysia, for example. So again, some knowledge in health economics there. Now, our next distinguished panelist is Prof. Gholam Farouk. So now, say hi, Farouk. Now, Prof. Farouk is he's actually now involved in the as a project director with the Bangladesh Cancer Society, and it's actually involving the setting up of a comprehensive cancer hospital and welfare home in Bangladesh. And he was the former head Department of Radiotherapy of Dhaka Medical College. And interestingly, I'm just looking at his CV now. Prof. Farouk has actually got some diploma and masters in health economics, and I think that's really very, very useful. And he has been involved as a health economist over the last 18 years or so. So there's a lot of experience that to be tapped into there. So it's really good that we he's made his time for this webinar. And last but not least, Prof. Suhar Tati. Hi, Tati. So
Hi.
she's fondly known as Tati to the rest of us. Again, Tati is no stranger to some of us here. She's a very senior radiation oncologist in the Department of Radiotherapy at Cipto Mangunkusumo Hospital in Jakarta. Tati was also the former president of FARO and also former president of CROC, which is the Southeast Asia Radiation Oncology Group. And she's currently the chairperson of the National Cancer Control Committee in Indonesia and president of Indonesian Radiation Oncology Society. So Tati has been instrumental in developing regional collaboration in education for oncologists and trainees through the establishment of CROC and her involvement in various IAA projects. Okay, and she does have special interest in health economics and equity. So those are our faculty for this evening. Now, without further ado, I'd like to invite Paul to give us his lecture for today. Paul, the screen is yours. Take your time to share your screen with us.
Thank you very much, everyone. And I hope you can all see that. Is everyone happy?
Yes, Paul, we can see it very clearly.
So look, usually twice a year, I switch the Towers of London to the Twin Towers of Malaysia. I'm a core lecturer with the European School of Oncology, as you've heard. And when we set up the Committee on Access for Innovation in Cancer Treatment, our initial thoughts were, did we have enough early trial centers, radiation oncology, medical oncology scientists in Europe? What we rapidly discovered was we had masses of innovation and ideas and trials, but we couldn't afford to innovate. We couldn't afford to bring those advances into practice. And as Asif has discovered, of course, I'm one of his more troublesome life members of the Malaysian Oncology Society. So I pop up at the meetings, and several of you watching, I'm sure, have had me as an examiner. So I hope the experience wasn't too bad. So I'm going to give you both a British and a Malaysian perspective today, because the fundamentals of what we need to talk about are the same wherever we go. And I'm going to summarize really a lot of what we do in our program in value-based medicine at the Malaysian National Cancer Institute, the IKN. And typically there we'll have 2 days. So if I go quickly, don't panic, invite yourself to our next meeting. Don't take notes, this is going to be recorded. We'll make sure that the slide decks can get to you in the future if you need it. So I've got a short time to cover 8 topics and the Q&A panel discussion. So let's get on with it. Why does cancer matter even in 2021, the year of COVID pandemic? Well, let's remind ourselves that the world of medicine is changing. There's no doubt that the senior panel is senior when you look at my grey hair and things like this. We've lived through an extraordinary change. We've lived through a change where most people died acutely of an acute event or an infection or an accident or in childbirth, to an era of non-communicable diseases. And here's the map showing the distribution in the world. The most important of them all is cancer. It's the leading cause of death worldwide. So for example, 1 in 4 Malaysians will get cancer by the age of 75, and this will double in 20 years. What about today? Well, look, a couple of weeks ago, I looked up the WHO data. We're averaging around 8,000 to 9,000 deaths a day from COVID. And it's a potential disaster, but it's nothing compared to the chronic diseases that you see before you. And that's why cancer is important. And as we come out of COVID, the backlog of patients will be even more important to treat. And we know how to manage cancer. It's very simple. This is this year's policy from the European Commission. We're going to prevent it, diagnose it early, and improve its treatment. So what are the future needs of our patients? Well, you can go to your national tumour registries and you can predict what will be needed in the future. But the International Agency for Research on Cancer, IARC, part of the WHO that controls cancer, will help this for you. And expecting this enormous increase, the Lancet Commission on Radiotherapy told us what the targets for radiation oncology would be, which they expect 8 out of 10 countries to have a comprehensive cancer plan. If you're in a low or middle income country, you should already have opened 1 new treatment center in the last 5 years. And we should include radiotherapy service in universal healthcare plans. 2025 is not far away. For that period, we expect to have increased our treatment capacity by 25% and trained thousands of healthcare professionals and raised billions of dollars to make this possible. And it would be interesting to ask, perhaps in the discussion, how close we are following this line of development. Well, can we grow the cancer budget through increased spending on healthcare? I think we might have done this a few years ago, but COVID has created a national shock to economies across the world. And so it's not surprising that you'll see similar headlines, whether it's the USA or India. Healthcare is unaffordable, unsustainable, and will only grow in the future. And therefore, if we have a global problem, we have a shared interest in a global solution. And here is the WHO report taking a global view. Global healthcare spend continues to rise. It's now about 10% of the world's economy is spent on health, about $1,000 per person per year. The health sectors worldwide have been expanding faster than the economy. They're taking more and more of the wealth of our nations. And the middle income countries, which make up so much of Asia, are rapidly converging towards the higher levels of spending that you'd see in rich countries, currently around 6 to 7% a year. Now, what's interesting about that is as spending has accelerated, access to treatment has actually slowed. And what's crucial about that is it's telling us we're becoming less cost effective. As we get more budget, we get more careless with it. We've got to learn to spend not just more, but spend well, because there's still a massive lack of access to even basic cancer treatments worldwide. And when it's there, it can plunge families into poverty. If we look at the shares of healthcare spending by the income of countries, you'll see that in every sector of the world, a large part of spending will come from out of pocket. And we know the impact of that in Asia because of the ACTION study. So looking at these Asian countries, we found that a year after diagnosis, around 1 in 3 of our patients had died. Half had experienced financial catastrophe, by which we mean it was consuming more than 30% of a family's essential spending each month. And just around a quarter were alive and financially sustainable. So it's not only a physical disaster, but an economic disaster for families in our region. The reality of cancer care now is clear. It's bad headlines. This is just a quick snapshot of the Malaysian newspapers, and I'm sure your own newspapers will look something very similar. Why don't we spend more money? Why can't we have the drugs? Why can't we have the treatment? Well, remember, cancer is not the only high-cost problem we face. All chronic diseases are increasing in prevalence, and it's worth looking at the cost to manage a case. Around $85,000 to manage a patient with diabetes. What about rheumatoid or an inflammatory disease like Crohn's, or needing hemodialysis? And you can see all of these are challenging the budgets that we have. And if in radiation oncology we want to make sure that we have the budget that we need, we have to learn how to advocate for the right share of the budget. And the headlines, of course, affect those specialties just as much as they do for us in cancer. So there's not only a shared interest in oncologists working together across the world, but in reality, all physicians and all patients and their advocates. So look, the plan for Asia is that we will have to double the cancer budget in less than 20 years to meet the doubling of demand. That's the challenge for Malaysia, and it's pretty much the same across middle-income Asia. So looking at the MOH data, can we get a doubling of the cancer budget, double the number of radiotherapy treatment centers, specialists, and all that go with it? Well, remember, we're going to have to compete because these are the changes we've seen in a decade in Malaysian healthcare, and that signals a problem. There is a significant pressure, and we will have to justify every dollar, ringgit, pound, peso that we can get as being of good value, worth spending on in place of other spending that we could use that money for. Now, planning the radiotherapy budget is very different from much of healthcare spending. Let me just explain why. A radiotherapy budget looks like this. There's a very significant piece of forward planning. It costs millions of dollars and many years to plan and build a new radiation oncology center. And Prof. Golam, I'm sure, will shake his head when he thinks of the hours he spent planning these sort of developments. And it's not only that, but you have to budget to replace equipment on a typical 10-year cycle. So radiotherapy budget planning is very closely monitored, and for good reasons. Now, the medical oncology budget tends to just grow by evolution. A new drug comes out, people advocate for it, spending fluctuates a bit, but year by year it gradually creeps up. And as you start the treatment policy for medical oncology, it tends to be focused on very valuable treatments, the so-called World Health Organization essential medicines approach. But in time, you'll see people wanting novel treatment, breakthrough treatments for which maybe the value has yet to be fully recognized. Now, with that huge upfront investment, we have to learn the skills of business planning. And here's an example. You can download this from everywhere. Hundreds of pages involving multiple stakeholders and a lot of data and financial planning, often decades ahead. Now, the MEDONC budget, as I've said, tends to be an issue that each year a new crisis comes and a new bit of money is allocated. And we don't typically tend to plan it on a 10 or 20-year time horizon. And that means that unplanned growth in the medicines budget within the cancer budget displaces potentially more effective spending on other cancer treatments. Let me show you how real that is. Looking at the decade between 2008 and 2018 in Europe, we've seen that more patients get cancer medicines. A higher proportion of them get it. They get more lines of treatment for longer periods, and those new medicines cost more. And that displaces spending. The spend on cancer medicines in Europe has doubled in that period by a matter of more than 10 billion euros. And you'll see it's taken an increasing component of our budget. It's now taking up to a third. So in 10 years, it's displaced 14% of the budget that we would have spent on staff, scanners, wards, surgeons, radiation oncology into the medical oncology budget. Now that is worthwhile if medical oncology is delivering 14% greater value. But ultimately, we need to plan that rather than let it happen by catastrophe. And when we look at advocates for cancer treatment, you have to ask, who's behind the push? The most recent reports suggest that at least 8 out of 10 advocacy groups will take funding from the people with an interest in using more of their products. And it's no surprise then when you look at how many cancer drugs have sold in excess of $1 or $10 billion worldwide over their time. And you have to work out which of those drugs do you think really makes a difference. You can see tamoxifen there selling around $13 billion in its lifetime is clearly a highly effective medicine, making perhaps a 10 or 15% absolute difference in long-term outcomes at 15 years for an ER-positive breast cancer patient. But what about at the top with bevacizumab here? Is bevacizumab really a life-changing drug that causes long-term differences in treatment outcomes? Name a tumor in which it increases survival by more than 5% in 5 years, and I think you'll find that a struggle. Now, when we get this wrong, cost checks are suddenly thrown at the oncology department, and they typically come in 3 steps. First of all, the support staff funding is withdrawn. Then there's halts and delays in investment in technical equipment and material. You know what it's like? The replacement budget for the LINAC, the new source for the HDR machine gets delayed. And finally, capacity and healthcare professional staff will be reduced as well. And all of those are a disaster for a system that requires planning 10 or 20 years ahead. So let's start making some capacity predictions to show how you can do it in your own health system. So I've gone to the IARC website, Cancer Tomorrow. I've selected all sexes, all cancers. I've taken Asia and picked out only Malaysia, all ages, and I've put the year for which I want to predict. And you can see that in the next 20 years, we will have to plan for another 45,000 patient capacity. We've pretty much got to double what we're going to do. In addition, I could tell you what the likely pattern of cancers are. In the short term, by 2030, that's only 9 years away, we've got to plan for 18,000 more patients. So we need to roughly increase the number of fractions we could deliver by about 30% within 9 years. Well, now there are several options to do that. And let's just look at a few of them. We could add new radiotherapy centres and expand the existing ones, dig new bunkers, put in new LINACs, hire and train more staff to increase it to about 130% of what we have now. We could extend the working day by around 1/3 with the current facilities, or we could reduce the need for radiotherapy by around 1/3. And we know there are some ways we could do that. We could hypofractionate, or we could stop doing radiotherapy and replace it with an alternative treatment, perhaps surgical or medical. Now, without planning for this, a crisis will develop, and you know what happens? We end up working extended days. But that's a disaster. So look, number one would be extending the budget and adding new facilities. And that means we'll have to engage with our health service managers to ring-fence funding year by year for those big budget items. So we'll have to learn the technical language for this and work with managers. A lot of doctors don't like that, but without it, our profession will fail. Extend the working day. Well, yeah, they always do that. But remember, when do you maintain those precious LINACs and planning systems? When do you update the software? It also means that when you extend the working day for radiotherapy, what about the pharmacy and the nurses and the transport system? The experience in the United Kingdom is that you can do it in the short term, but once it becomes prolonged, then staff losses increase, and actually you can be worse off by the end of 1 year. What about reducing the need for radiotherapy? Well, hypofractionation is a very interesting step. So look, basically for palliation, we've been very good. I suspect most centres in Asia are using wherever possible single fractions for bone metastases, short course palliation for lung cancer, brain tumours, and so on. And so the big savings will come from the big budget items in terms of fractions: breast cancer, prostate cancer, head and neck cancer, advanced pelvic cancers. And some of those will be amenable to this treatment. So, for example, prostate cancer. And we know that you can reduce radiotherapy fractions. There have been the sort of fraction reductions we need, about 30% already proven in Canada and Australia. But there are problems with these studies when you look at them. By the time those studies had reported long terms, the conventional arm of treatment had moved on. Radiotherapy planning was now 3D, or indeed IMRT. The pattern of patients being treated had changed because external beam radiotherapy was being displaced by brachytherapy for organ-confined medium-risk disease, and for the low-risk patients, surveillance had replaced active treatment. So now we're trying to compare apples with pears, and we're playing catch-up with a trial that takes a year to set up, 3 or 4 years to recruit, and 5 years to report. Well, we could go for broke and go for really extreme hypofractionation. But we know the problems with that. Rectal toxicity is dependent entirely on your planning volumes, whether it's acute or late. And that dosimetry requires equipment, training, time, and money. So my conclusions are we can do moderate hypofractionation probably with the current technology, but the comparator arms of those studies are no longer seen as standard of care. And if we really want to catch up, we will need investment too. Now, what about replacing radiotherapy with surgical or medical treatment? For example, giving chemotherapy to advanced lung cancers, whereas in only 10 or 15 years ago, we might just give 5 fractions of external beam radiation therapy and leave it at that. What about giving bisphosphonates, for example, and delaying the need for radiotherapy for bone pain in advanced breast cancer? Well, now the trouble again is that this sort of transition happens in 2 ways. The unplanned way, the patient pathways suddenly dry up. Where are all the patients needing treatment with X, Y, Z? And you discover that there's been a change in medical treatment and a new pathway is coming. They're giving neoadjuvant chemotherapy, for example. Or better, that we meet together and plan pathways of care so patients move through the most cost-effective and clinically effective steps in the best order. And that brings us down to a fundamental problem in all of this. How do you compare apples or pears? And crucially, what would be a better treatment? What do we mean by better? And that's fundamental in spending the cancer budget and advocating for it. So let's get back to think, what are we in medicine for? Well, we're here to satisfy the patient, and they want to live longer and they want to live better. But we also have to satisfy the healthcare system, and their aim is to maximize the health outcomes with the resources that we've got, to help as many people as possible live longer and live better. Now, we measure that in terms of health economics in these metrics. To live longer is the added life years. How many added life years do we get by treating advanced head and neck cancer with radiation therapy? But also we want to live better, and we therefore need to know the quality of life. There's no point replacing the toxicity of a tumor with the toxicity of long-term radiation side effects. And the metric for those parallel aims, of course, is to multiply the ALI by the qual and get the QALY, the quality adjusted life year. And so the aim of a health system is to maximize the number of QALYs you can get from the resources that you have, the cost per QALY. Let me explain really what a QALY is, perhaps in a picture term. Treatment A increases quality of life and length of life over our standard of care. That's a clinical advance. Now, intervention B doesn't make you live longer, but it makes you live better. That could, for example, be high-tech radiotherapy planning and delivery to avoid toxicity. And the area between those lines totaled up will be the total number of quality adjusted life years we have gained. So we would like to have intervention B if we can afford it, if it's worth doing compared to other things we could do with the same money, staff, machine time, scanner time, and so on. So the key question, is it worth it? Now, economists use the cost-QALY model to assess the benefits of treatment. So let's show we can do it. If I live 1 year at full quality of life, I've gained 1 times 1, that's 1 QALY. If my treatment made me live 2 years longer at 70% of full quality of life, I'd have gained 2 multiplied by 0.7, that's 1.4 QALYs. If I lived 6 months longer at half of full quality of life, I'd have gained 0.5 times 0.5, 0.25 QALYs. Now, because this is a radiation oncology audience, this should be easy. If I make you live 3 years longer at half quality of life, how many QALYs have I gained? And of course, the answer is easy, 1.5 QALYs. Now I've got to go and justify why I want that treatment. And I know that that treatment costs around, say, 15,000 euros. What would the cost per QALY be? And again, because you're oncologists, this will be easy. It's costing around 10,000 euros to add 1 year of good quality life to patient care. And I would take that data to my manager and go, I really want this treatment. It's good for patients and it's good value. It delivers real demonstrable benefits for the patient and is within an affordable price range for our health system. So we have to think now about whose perspective we're responding to. And here's the trouble. The patient, of course, wants what is best for them. I want proton radiotherapy. But the pair perspective would be, well, what's good for society? If I can treat 1 patient with protons and 100 with photons, where does the balance lie? So where do I get the best health for the patient? And where can I deliver the most health for the population from the resource, the budget, the staff time that I have? And there will always be a tension. And this explains why medical decision-making is changing. So in oncology, before evidence-based medicine, when Prof. Golam and I were medical students, We just focused on a mechanism of action. Did the tumor shrink with radiation therapy? Did the drug make it shrink? Then we realized, of course, that we had to focus much more on efficacy. That was evidence-based medicine. And for many years, I've taught this. I'm a Cochrane editor. And the evidence-based medicine question is very clear. Do you live significantly longer or live better as a result of having treatment A versus standard of care? But because of affordability and the staff shortages and equipment resources problems we have, we've got to move on, the WHO says, to something called value-based medicine. And the key question for that is this worth doing compared with other things we could do with that same resource? For a patient, the resource might be time, and obviously for a radiation center, it might be fractions and time on scanners and machines. So when we demonstrate the value of radiation oncology, let's think of the settings and how we'd show it. So if I can cure an otherwise incurable advanced head and neck cancer, my aim really is to gain ALLEs without toxicity. So we want to see the cost per QALY. One of the things that radiation oncologists often complain about is that many of our treatments don't make you live longer, but they make a huge difference in terms of organ preservation, whether it's your larynx or your bladder or your breast. And for that, we have to show a real quality of life benefit that's durable and isn't taken away by the toxicity of late radiation side effects. Many things we do prolong their life with advanced cancer. There's plenty of treatments we do for that, whether it's brain tumors, bleeding cervix cancers. We have very effective treatments for that. And therefore, we want to prolong life whilst maintaining quality of life. There's pure palliation. Then, of course, many things we do are to save resource. We want equivalent outcomes from alternative treatments. And in all of those, we need to deliver the data on the cost for the quality adjusted life years gained. So that tool is going to be crucial. Getting the Q part of the ALY will be important for almost everything that a radiation oncologist will do. And this helps us compare apples and pears, because a QALY is a QALY is a QALY. A QALY gained for a patient on a dialysis unit by having a transplanted kidney would be the same value as a QALY for a patient with advanced head and neck cancer who we cure with radiation. Now, the trouble with quality of life measurement is each specialty tends to have made their own. There's one for Parkinson's disease, there's a diabetes one, we've got lots for cancer, there's a depression one. But if we want to compare apples with apples, we need a generic quality of life scale that works for every single patient and disease. And in Europe, we have the European multi-domain scale. It's been validated in all sorts of different diseases, and it can be converted directly to the term that economists want. We can do a study in Britain, and you can convert it to Malaysian data because we've already made the conversion factors. And that means we can work together, for example, across FARO, to share the workload. Let me show you the tool. It's 5 simple questions with 3 possible answers. And you ask about the patient's mobility, their self-care, whether they can do their usual activities, whether it's work or working at home, whether they're in pain or discomfort, and what is their state of anxiety and depression. And it's a simple checklist to do. It's available in 127 languages, and finally we ask them to put their mark on a visual analog scale. Now, I've just done a study where we introduce this routinely into eye clinics because we don't know the value of, for example, reducing blindness in people with diabetes. And what we showed was that these are questions you should ask a patient at every visit anyway. How are you? What's your mobility? Can you self-care? What's your level of pain? How do you feel? Can you work? Can you fulfill your roles at home? And it takes around 3 minutes. And when it's introduced systematically for every patient in a clinic, it in fact can save time by focusing you on what matters for a patient. So for mobility, you ask, do you have any problems? And the patient will give you a checklist. Perhaps they have some problems walking, some problems washing and dressing. They've got bone pain from their metastases. And therefore, they've got problems performing usual activities. They're in a lot of pain, but they don't feel anxious because they know you can help them. And they tell you what their quality of life is on a scale. And you'll see we have 5 potential scores with an outcome of 1, 2, or 3. That gives us 243 potential results. And I can look that up. So that score, I can discover what it is. and I can work out what the quality of that time would be. So that patient has symptoms somewhere between severe angina and rheumatoid arthritis. That is a patient you would want to treat, and you would be happy to relieve their symptoms. We are able to compare apples with pears when we advocate for our budget. So should we invest more? Well, what's the benefit it'll bring? What's the cost we need to deliver that benefit? And is it worth doing compared with other things we could have done with the extra LINAC, planning system, physics time, oncologists? We measure that by gain in QALY, the incremental gain in cost. What does it cost to deliver that QALY? And of course, the budget impact. And that means that physicians, oncologists, will have to sound a bit more like economists. And what I want to tell you is that they are very similar skills. In both, we have to be realistic. We rely on quantitative information. We have to make difficult decisions about the future in the face of uncertainty. Will this treatment work, and will I be cured without toxicity? Well, I can make decisions about the best paths to follow, but I can't guarantee it. We know that good decisions require comparing benefits and risks, whether it's toxicity or costs. Now, there are some big differences. Remember, we deal with each patient one by one, or small numbers of patients, and economists typically think of patients in a big group, all the patients with cancer in Malaysia, for example. And that explains why we have a tension between us when we meet, because we want the best for our patient, whereas the health service is concerned with the total health of all the people they represent. So we have to understand the language they're going to talk. And economics, I promise you, is really simple. Price is what you pay and value is what you get. Diamonds cost around $7,000 to $8,000 per carat, and I promise you they don't make you live longer. That's the cost and that's the effect. Now compare it with water. You can buy a cubic meter of water in Malaysia for around half a ringgit, around 50 cents. And I promise you, you'll die after around 3 days without water. So which is the more valuable thing, diamonds or water? And the answer is easy. Of course, it's water. There's one second thing you have to learn to be a health economist, and this is this. Each ringgit, peso, dollar can only be spent once. Once you've spent it on one thing, you've lost the opportunity to spend it on something else better. If you buy a proton machine, you may have sacrificed the funding for 10 conventional LINACs. Now, remember, economists never say things are cheap or expensive. They're either good value or they're not. We could invest, for example, in chemotherapy to go beyond simple palliative care for patients with advanced colorectal cancer. And over time, new generations of treatment have extended the lifespan of patients, which makes it a potentially very useful treatment. But it's worth looking at the increments of that advance. To add the first year of good quality life costs very little, but to add that second year costs a fortune. And we may have to choose which of the steps is the one we don't go beyond. So for example, we could ask, what should we recommend in FARO for post-mastectomy radiotherapy patients? And in the American NCCN guidelines, there are 183 pages of guidance and another 100 or so of references, but there's only one page discussing the principles of what we do. So let's help them out a bit. There are lots of treatments we could offer, but let me tell you that the value of treatment is driven in the long term by the risk of cardiac toxicity. And it's no surprise that we've worked to reduce the cardiac toxicity by all of these advances in chest wall treatment. Now, none of those advances is worthwhile, by which I mean it's not worth doing unless you're willing to pay $50,000 US for each additional year of good quality life. And this is, of course, US data. Now, put that against the Malaysian annual household per capita income, which is around 1/10 of that, and you'll realize why that would be a challenge to afford as national policy. We could look down into these steps and see that giving IMRT to shape the beam away from the heart comes in at around $30,000 per QALY in the US. Now, since that might be, of course, upfront investment in planning systems and LINACs, A lot of it may, however, be staff time, and therefore interpreting this to Malaysian wages might be an interesting comparison. But the others, you'll see, the next step up, for example, should I refer people to protons, come at an extraordinary incremental cost. Now, when we find that treatments aren't affordable, we shouldn't just stop. We should ask, is there a subgroup who benefits? And being radiation oncologists, we know instantly this. Should the FARO recommendations for post-mastectomy radiotherapy be different whether the tumour is situated on the right or the left side of the chest? Think about that. That might be the way to bring it in. Now, let's show that we've learned this by very quickly putting ourselves in charge of the National Cancer Budget allocation for 2022. We've been promised that we've been given 3,750 million gold coins, and different groups in the oncology centres have put in their bids. And every single one of these bids is very good. They all add one QALY, but they have different costs to deliver that QALY. So we have to decide how to spend it. Well, let's start by getting the health technology assessment team in which case we'll buy all of the most cost-effective treatment first, and then we'll buy the second most cost-effective and carry on until we've spent the money. And we'll find that we can fund around half the treatments requested this year and reject the other half. And that will gain us our budget spend and an outcome. Now, of course, we could be fair. Because there'll be some people who don't like that, and we could be fair and we'll buy all treatment equally until the budget's spent, in which case you'll see we'll run out of funds for the novel treatment after about 3 or 4 months. And for the rest of the year, the machine will stand idle, the drugs won't be given. But it's fair, and people like fairness. We could go for the political interest model. There'll be some groups that have good advocates behind them, and politicians don't like bad news. This is the Austrian Parliament during Breast Cancer Awareness Month. Now, no one sticks a 10-metre high pink ribbon on the Austrian Parliament if they don't think they're going to influence the voting of the people inside it. So they could swing the decision and get, for example, breast cancer treatments funded. Well, now, ultimately, we have to say what delivers the most health for the most people. And you'll see that I get many more QALYs by following the HTA route than any other route I could do to make that decision. But this tells you that making those decisions can make you unpopular. It's not a very easy task. And that's why we all have to sign up to this and get our colleagues to work within these rules as well. Because we have to imagine what happened if the Ministry of Health followed that assessment and funded those and refused, for example, to fund any new cancer drugs for 2022. Would we accept the result? Or would we call up the advocacy group and march on Parliament waving banners? Now, one thing that the WHO says is that every health system has waste and inefficiency, and if we all learn from each other, we could save money. This is the More Health for the Money programme, which I advise you all to read. It's a wonderful document full of great ideas. And it says this: you can't manage cancer without innovation. And here's our current budget. And every time a new machine comes, a new technique, a new drug, we have to go to our payers and demand more money. We need an innovation fund. But everyone needs that, whether it's cardiology, neurology, oncology. The WHO tells us that we should look every year to take out savings from the current budget that don't compromise care and reinvest that in an innovation fund year on year. And that will sustain healthcare. Now, for this, we have to identify equally effective but cheaper treatments. And you can think of lots of those: generic drugs, biosimilar drugs, short course radiation therapy, if it doesn't require significant extra resources. Now, can you really make significant savings from within our current budgets? Well, the Lancet Commission says, yes, we can. This is another key document that you should all read. And it says there are 6 things we can do. The first 3 are easy. Don't give a patient a treatment with low or unproven benefit. Now, we'll perhaps discuss this at the panel. What is an unproven benefit? And we know that ESMO and ASCO has been working on the idea of the minimal treatment benefit before treatment is worthwhile. The next step would be don't give a patient a treatment that they don't want. People vary in what they want from treatment outcomes, so consent, informed consent, is very important. Don't duplicate tests. Don't do a CT and an MRI on the same patient if you only need one. And of course, lastly, focus a lot of our research, equally effective but cheaper treatment exists. For example, generic and biosimilar medicines, short course trastuzumab adjuvant therapy, day case surgery, hypofractionated radiation therapy. And the idea is that there is a lot of spending locked up that more efficient use of our resources could free. So in Europe for cancer, for example, the spend for each cancer patient varies threefold between countries without clear evidence of any significant benefit by spending more. Put that data the other way around and you'll see that we could improve outcomes by 25% absolute for no more money if we were as cost effective as the most cost effective system. And that tells us we need to choose between treatments. We need to choose better treatments, not just to choose more treatment. And this tells me the key skills we're all going to need for the future, particularly in radiation oncology. Well, the core part of FARA has been to teach to be a competent caring oncologist, but I'm telling you, you now need to be able to assess the value of competing treatment options, be fluent at reading a health technology assessment, be experienced in writing and advocating for those budgets that we need in the future, need to understand how to design and run comparative outcome studies, the studies that show we can deliver more for less. And all of those will require training because it doesn't come naturally. Let's look at this issue about advocacy. You have to sound something called the cost effectiveness plane. We start from where we are. What are we currently doing? And we hope the new treatment will give us a better clinical effect, but we accept it might cost more. And we know how to measure this, the QALY. And we will say we have a clinical effect for the treatment here that is gaining some QALY benefit at some cost. And we line it up. We say that's the slope of the cost effect ratio, the incremental cost effectiveness ratio. From that, we can calculate how much would it cost us to buy 1 year of good quality life. Now, that's the key metric. And the WHO tells us when we should advocate, when we should go and demand the budget. There's a threshold of cost effectiveness below which we should have it funded. There's a level above which we should be told to go away. And the WHO is telling us that when you can add 1 year of good quality life for less than the average income that that person would earn, that becomes good value. If it's more than 3 years earnings for 1 year of good quality life, you should almost certainly reject it. And of course, somewhere in between that is a dividing line. Now, in a state-funded central health system, that will be decided by willingness to pay, what I can get from the Treasury. In a private health system, that's decided by the depth of patients' pockets, by their ability to pay. Now, perhaps some of the most publicised decisions are made by the health technology assessment part of the United Kingdom Health Service called NICE, the National Institute for Health and Clinical Excellence. So when we have a treatment that's better than standard at a cost, we will work out its cost per QALY. And if it's below our threshold, our ISA threshold of 30,000 British pounds, around $40,000 for 1 extra year of good quality life, you'll see that that is a treatment we should be able to advocate for. What about the second treatment we might consider? And you'll see this one, unfortunately, comes above our threshold. And that would not routinely be appointed. It would be reimbursed. Now, to generate a lot of these studies, we'll have to understand what we mean by comparative outcome studies, delivering more for less. So imagine hypofractionation could deliver a similar QALY outcome with fewer resources. It would become the more cost-effective option. We'd displace it. But the key question is to decide, well, what do we mean by similar? How similar does it have to be? Let me show you a challenge, because this is fundamental to understanding an equivalence trial. Have to read the report. An equivalence trial has a primary objective of showing that the difference between two or more treatments are clinically unimportant. They're not superior or inferior to another, they're similar, they're not identical. And the first key step is to decide what would be the difference that we would accept before that treatment was not similar enough. And that might require, for example, putting a patient panel together, looking at the trials, but that's the key. It's called the equivalence margin, and that will design the study. So, for example, in looking at the conventional 2 gray per fraction prostate external beam radiotherapy trials, those arms, you'll see that if I take the big trials that have been published, the average progression-free survival long-term is around 3/4 of patients, but the range is not identical. Well, we don't expect that, do we? We don't expect the same outcome on every trial because we understand that the outcome for patients is driven by patient factors, age, comorbidity, by tumor factors, by treatment factors, and of course, indeed, by chance as well. So what is the acceptable outcome that we would say was not really a clinically significant difference? And this is the delta difference for our equivalent study. So what are the results of an equivalent study when you read it? And this is quite complicated. So let me show it graphically. We have an equivalent outcome. It's neither better nor worse. It's similar. It could be not equivalent. This study could just be underpowered, but the answer is it's not equivalent. It could be not equivalent. It could be not equivalent. There's only 2 results. It's equivalent or not equivalent. Now, in radiation oncology with hypofractionation, you might just be interested in one arm, showing that it's not inferior by saving resources. And this is called a non-inferiority study. So let's put the data back in again. Non-inferior, inferior, not inferior, inferior. And here's the challenge. With a non-inferiority study, you could miss a trick. Remember, the alpha beta of some tumors might make hypofractionation actually a better treatment. So let's look at the statistics. And I'm glad Fuad's here to help me out because he'll put me right when I get this wrong. But suppose you expected an outcome of 8 out of 10 patients controlled long term, and you accepted an equivalence margin of, say, 4%, a 5% difference, relative risk difference in outcome. That now sets the equivalence margins for our study. And I can do statistics that tell me to be 90% sure that it's neither beyond that limit above or below, or 95% for just one of them. With a difference of 4%, I need around 3,500 patients. This explains why, if you're really serious about equivalent outcomes, large patients, multinational trials are required. So let's just take a look at a few classic studies just to show how it works. This is the ultra hyperfractionated Scandinavian hypo trial. And you'll see, being clever statisticians, Fuad will, their equivalent, help them, they pre-specified a 4% non-inferiority margin, and they hit that target without increasing toxicity significantly. Let's have another one. This is the Herceptin study, the MRC Persephone trial, which said, is it non-inferior to give half the duration of trastuzumab? And the pre-specified 3% margin was set by interviewing a patient panel. And they said, plus or minus 3% is no big deal to us. We wouldn't change treatment for that. And you'll know that this trial hit its target. But of course, there are people who would advocate for 12 months. Although remember, the QALYs in each arm are different. If the outcome is the same, but you significantly reduce cardiac toxicity, one arm has gained more QALYs than another. So from a health technology perspective, this is not an equal trial. This is a major advance in patient care. But it isn't always so good. If you want a journal club, last month's JAMA Oncology brought you this trial. Now, should you give patients who are frail and elderly with advanced ovarian cancer carboplatin and paclitaxel, or just single agent carboplatinum, or weekly carboplatinum and Taxol? Well, some of us may have thought about this, but when you look at the trial as it's come out, there is no pre-specified inferiority margin built into it. 48 cancer centers recruited patients over 4 years, and you'll see that they managed 12 patients a year in 48 cancer centers. Now, the primary outcome was to see who completed chemotherapy, and secondarily to see 2 to 3 years later which was performing best in terms of tumor control. And you'll see that the trial committee looked at the data when it was 120 patients and decided to cancel the trial. And they have written that clearly single agent carboplatinum gives worse outcomes in vulnerable patients, and you should flog them with platinum and Taxol. Now, for those of us that have done a lot of gynae oncology, remind yourself of the other data, because we know the statistics matter. So suppose you expected around 60% chemotherapy completion rate in a frail elderly group, and you accepted a 10% relative risk of inferiority, that would set the inferiority margin at -6% or 54%. You need around 2,000 to 2,500 patients in a 2-arm trial to determine that. What can you determine with a 120 patient 2-arm trial? Well, you can determine an inferiority of 26.5%. So are the conclusions of this paper in JAMA real? I would say not. And you can see why the letter to the editor is being typed as we speak, because also many of us randomized patients to the ICON-3 study, thousands and thousands of people, which showed no difference in fit women between single agent carboplatinum and multi-agent chemotherapy. So my conclusions. We are all in trouble. We need to work together. We have to learn to give only the most clinically valuable treatments in the most cost-effective way. We need to engage now with all our stakeholders, that's the patients, the patient advocates, and the people who fund us, to get agreement on how to move forward, particularly for us who have to plan decades ahead for our facilities. We know that focusing on value-based medicine will be good for our patients, because value isn't money, remember. Value is this. It's things like length of life and quality of life. And there are many ways of looking at that. It could be avoiding hair loss and fertility, the ability to keep working through treatment, time without symptoms of toxicity, and many more things. But we need one measure that will bring that together, and that will be the QALY. And what I'm asking you now is to consider every time you see a patient in your clinic, just ask those 5 questions, tick them off, stick the piece of paper in the notes, because you will then soon demonstrate the value that you are creating for your patient population and in every trial. Remember what the Lancet Oncology said, is it worth doing? What clinical difference would you say was valuable to you? So if I offered you 6 months of toxic multi-agent chemotherapy, what would you want it to do before you'd say yes? Would you accept it to live a day longer? Or what about a week longer? Or what about a month? Or what about 3 months? Would you want 6 months or a year? Well, interestingly, we give a lot of chemotherapy with quite marginal benefits, but a survey of patients, this is the Silvestri study, suggested that the threshold at which at least half your patients will accept chemotherapy when they really think about it is a 9-month survival benefit. So we really want to think what a minimum benefit of treatment will be before we advocate for it. We need to be fully focused on value-based medicine, and all you need to know is in these documents. We must believe it'll work, that we can both improve outcomes and costs by learning from each other. And for that, we need you to publish your work. How many of us knew that India and Bangladesh had adopted 4 fractions twice a day of external beam simple planned radiotherapy for advanced head and neck and cervix cancers, which gives amazingly good palliation for swallowing and bleeding. And those patients 2 or 3 weeks later can sometimes be converted to radical treatment. Now, I never learned that until I became a research fellow at the All India Institute for Medical Sciences in Delhi, where I spent half a year. We have to also not be envious. When we're told that America has the best healthcare system in the world, we should learn, show me the data. Sure, America spends a lot of money on healthcare, but in terms of their performance, what about the outcomes? Wouldn't you rather follow these 4 countries, and all of the best performing healthcare systems have all adopted value-based medicine, health technology assessment, QALYs and cost per QALYs as the core of decision-making and budget planning? So we have to have confidence to make decisions that are right for us. When the trainees tell me in the exam that the NCCN guidelines recommend treatment A, my blood pressure goes up, because the answer is, what gives value to the patient? So FARO is very important. Remember, half the world's cancer patients are now treated by just 15 Asian nations. So we need treatment guidelines and policies that are appropriate for us in Asia. And that often means we need our own research. Sustainable healthcare means that we have to adopt these policies and get the skills to our trainees to make this work sustainably in the future. Because economic thinking will help us decide how best to use the resource we have, and it saves lives and sustains healthcare for all. Now, I'm just going to finish by saying it's not all about money and it's not difficult, because value is many, many things. And let's just think about the career choice that we've made. Yeah, sure, cancer has the greatest global impact of any threat to life, but what does that really mean for an individual? Because the moment you're born, your life is ticking away. And it's worth looking at what those risks are. Well, we've trained in radiation medicine. We have given up on average 12 days of life by not choosing medical oncology. We could live in a country where they increase the speed limit. We could be drafted into military service. We could look at the accident rate. Who would drive a scooter in Kuala Lumpur? We could be a bit overweight. Some of us have this problem. We could be in a difficult job. There are worse jobs than radiation oncology. We could smoke. We could be unmarried. We could have heart disease. Indeed, you can die of a broken heart, it seems. And even worse, you could be male. And where in all that scale does cancer fall? The answer is there. There are worse things than cancer. So we want to look for all the opportunities we have, and most of the best things in life truly are free, as every religion will teach you. And I have to say that in all the value-based medicine sessions that we've run at the Institute of Cancer Research in Putrajaya, just outside Kuala Lumpur, we have never charged anyone anything, and you get free tea. So I thank you all for giving up the most valuable thing that you've got, your Friday night, and set us up for the panel discussion. Thank you all so much.
Thank you very much, Paul. I'm sure you all agree with me. It was such a comprehensive lecture. There's, a lot of things that it's really kind of, I've actually listened to Paul's lectures, similar sort of lectures, I think many times now, but it's still always a learning, point for me, and quite an eye-opening session again. So I'm sure, the panelists,
remember,
will feel the same.
My job is to make you all read a bit further and start with that WHO document, More for Money. Or, God save us, when the COVID problem is over, we'll be running yet another course at the National Cancer Institute in Kuala Lumpur. And the last time we discussed with the health minister, he said he was very keen because we'd heard rumors from other countries that why, for example, weren't the Singaporeans invited? The answer is we'd love you all. And there's a limit to how big the lecture hall is, but we should certainly work together across FARE, shouldn't we?
Yeah,
sure.
that was a different health minister, and you won't get free tea after this because it's all virtual.
Okay, so I think our next session is basically just to invite our panelists, some comments and opinions, and of course, Q&A, anybody from the audience for that matter. So I think I can see, some sort of like messages in the chat box. We will come to that in a while. Can I just invite each of the panelists perhaps for some comments and opinion? I know Paul has actually also put together some sort of like discussion points in case, we're not quite sure what to ask in the session. Very kind of him. And I've actually put that on like a Words document, and I can share the screen, like, if you're just going to go through some of those important points. Can I get, I don't know, I suppose Fuad then to make some comments first, and I will just, take it in turn from there.
Yeah, thanks, Anita. So one of the points that I always am interested in what Paul said towards the end, So when a student says, "Oh, this is in accordance with the NCCN guidelines," and that's a very difficult point because you have students who will advocate the sort of the latest treatment for perhaps very minimum benefit, and has the potential of eating up like half your drug budget or something like that. So that's the sticking point. Aren't you supposed to do the best for your patient and not worry about the healthcare system or whatever else that comes around? So it's a very difficult question for any one of us to answer. Yes, the patient, but for me, the patient in front of you is very important. But then again, it's all about being equitable. That means you have a certain cake of a certain size, and you need to distribute it to everybody. You can't be using 10% of your cake for just one person. it leads to very difficult discussion in the clinic, and also very difficult discussions and very challenging exam questions as well. Yeah, you can expect a slew of different answers from the brighter candidates, perhaps, in that way. And of course, as they rotate to different departments or different centers within our system, then we can see that there is some difference in the practices of the different centers, right? I think we are a bit more conservative compared to the others, because I always put an emphasis on, don't break the budget, make sure that you have enough for everybody, make sure that everybody gets reasonably good treatment. Maybe not the Rolls Royce, but at least you're getting around with a nice Toyota or something like that. That's my 2 cents worth. Maybe Tati can take over the next
Yeah.
comment.
Yeah, thank you, Fuad. So again, I mean, like in Malaysia, we do have, I mean, to a certain extent, again, we're still fairly new, finding our feet around this value-based medicine concept. And Paul obviously has been a lot of help as far as oncology treatment is concerned. I don't know then, Tati, in Indonesia, do you have a similar sort of like maybe committee, or or something to look at, value-based or even cost effectiveness in radiotherapy, and proposing, policies, for example, to the higher authorities like the Ministry of Health in Indonesia, for example. Can you just share with us some of your experience?
Yeah, okay, thank you, Anita. Yes, in our Ministry of Health, they have like a health technology assessment committee that actually have to do the cost-effective analysis for each treatment and decide which treatment is the best. But sometimes it is not so work well, and maybe we have to learn from Paul how can we advocate them to do it in the right way. Yeah, for example, they are still thinking about whatever the the very expensive drug, and then we sitting together, but not really calculate in the right cost effective analysis.
Again, I can understand it, Tati, because most of us, we are not trained as health economists, but like Paul says, with a bit of effort, all of us, I mean, most of us, if not all of us, could actually, be partly in the health economists, and we have no choice really, because treatment is getting more expensive. And after COVID, somebody's got the hand up there. Is it Paul there? Go on, Paul.
Because I think it's a very important point. Remember that when a novel drug comes out, typically the company that makes it will fund health technology assessments and will help advocacy groups make their case. But a photon is a photon and a photon. It's the same photon whether it's from a Philips, Linac or a Mitsubishi. And here's the trouble. So we have to learn as a group of professionals in radiation oncology to use the same language, the same metrics, and make our budget case in the same way. So I think the skills are transferable. And that's where you'll see a lot of health technology assessments for new drugs, but increasingly through the work of ESTRO in Europe, we're beginning to see them for new radiation technology. So I showed you, for example, the choice for chest wall, which suggested that the incremental cost effectiveness for giving 3DRT to breast cancer post-mastectomy was quite a challenging decision. But once you're fluent with that, you could say, well, it makes no sense to use it on the right side of the chest. It's about the left side. And that, you see, could double the cost effectiveness at a stroke compared to the standard of care. And so by being fluent with this and by adding health technology assessment papers in your journal clubs, I'd hope that people are ready to say, that sounds good to me. And when the medical oncologists say we're going to give combined paclitaxel and carboplatinum to older elderly frail patients with ovarian cancer, someone will say, no, that JAMA paper is a load of old rubbish. It doesn't show the inferiority of carboplatin. It shows the play of chance. It was a wholly underpowered study, and it was analyzed post hoc without its primary data, and Fuad would tear them apart in the exam for suggesting that. So this is the idea that by learning the language, by discussing it, making it every day in how we talk to patients, how we talk to each other, how we make decisions in our tumor boards, that we will learn to advocate so much better. And then share it across Faro? As I said, we run 2-day courses at the IKN in Malaysia. Do we need to divide that into 10 one-hour teaching sessions that we run across Faro over 2 years? Maybe that's the way to do it.
Yeah. Okay, Prof. Farouk, I mean, if you'd like to share your experience, any comments, with regards to how you do things in Bangladesh.
Thank you very much for giving me the floor. And first of all, I want to say that we don't practice the value-based medicine in our healthcare system. We are practicing a fee-for-service. So that is the very conventional approach. But this is the high time to incorporate particularly the value-based medicine in healthcare system, where the health economics should be included. As you know, the economic evaluation is very much mandatory to give the best management with low cost to our patients. And this economic evaluation, I think that at least there are 4 tools to evaluate the cases, or in the perspective of health economics, that is cost minimization, cost effectiveness analysis, what Paul was telling about that, then cost benefit analysis and cost utility analysis. But the foremost thing is that what advocated by Astro Hero project, where the 6 elements of value-based is safety, effectiveness, then comes the patient-centeredness, timeliness, efficiency, and equity. These 6 elements, we are not always very much concerned when we come across our patient one-to-one conversation. But the scenario is not same in rich countries where per capita income is more than $10,000 US, and where the per capita income is less than $3,000 US. The scenario is heterogeneous. So we have to very much concern about the need-based management. And there are 5 types of needs. One is the felt need, which is the patient himself desire to have treatment from the healthcare facilities. Then comes the normative needs, where the expert's opinion is there. Then comes the expected needs, what we have, what we want to have. So the demand creation. And then comes the comparative needs. In Asian region, like in China, Japan, Korea, they have one scenario. In Bangladesh, in Mongolia, in Sri Lanka, there is another scenario. How much radiotherapy facilities are available and what high-tech radiotherapy facilities is available. So comparative need also there. But another thing is that there is anticipated need. That means in our Bangladesh, in 2018, when this government came into the power, they have election manifesto. They announced that they will build 8 divisional cancer center. So this is the anticipated need, but till date, it is in planning position, not in for the last 3 years. We couldn't have any establishment of that divisional cancer center. So the need-based issue is one of the core things, and according to our socio-cultural economic situation, and Bangladesh is trying to practice those things, but the resource is very limited, so it's very difficult to fulfill all those things. Thank you very much.
So, Prof, I'll be on the plane to Dhaka as soon as they can get us free. If you think you're in trouble, I had to go and help in Tanzania. Now, Tanzania is a country in sub-Saharan East Africa. And what's remarkable is that value-based medicine overall has delivered the most cost-effective drugs for what were the major health conditions of sub-Saharan Africa: tuberculosis, malaria, and HIV. And by focusing on that, what has happened is that the life expectancy of patients has risen so dramatically that cancer is now a bigger cause of death in sub-Saharan Tanzania than malaria, TB, and HIV, and now means that we've got to invest in cancer. So there's a very important point here put up by Dr. Tamaki. So thank you for putting that one in. Whose perspective do we look at in terms of value? And he's right to point out, of course, that one of the huge advantages for value-based medicine isn't just for state healthcare systems and centrally funded ones, but for private healthcare systems. A sustainable business means that your customers can afford your service. So whilst you plan to open the 8 comprehensive centres that we hope will be fully based around value-based medicine, sustainable private fee-for-service medicine also is driven by value. And the experience I would point to is the United States of America, where 20 years ago, the majority of cancer care was delivered by what were called community clinical oncology practices. The increasing cost of cancer medicines and treatments has driven those out of business. They've been taken over, and it's now one of the fastest shrinking businesses in the world. So if you want a sustainable fee-for-service healthcare business, emphasizing that you deliver value. Now remember, value for patients is more QALYs, and thinking about their out-of-pocket costs, more QALYs per resource, then that will work. And we had a long debate in the Ministry of Health in Kuala Lumpur. We, for example, built a comprehensive program to drive up the use of generic and biosimilar medicines in the state healthcare cancer service in Malaysia. But the group that needed it was the private healthcare system, because the Malaysian healthcare plan is based on the idea that the state healthcare system hopefully will look after the poorest half of the population, while we encourage the richer half, the middle class and wealthy, to take out supplementary insurance to bring them to your fee-for-service clinics. So whoever's perspective, value-based medicine will be the answer. So like I say, I've been to pretty much every country in Asia. I've taught this in America, Russia, and China, and I've been a fellow in India, so it's no problem to nip across the border, promise you. And even in Pakistan, so they let me across the border there, despite being a trainee from the University of Delhi.
Okay, we've got a couple of questions in the Q&A box, and there's one question still in the chat box. Maybe we just finish off the one in the chat box. There's only one more, which is from Miriam. It's, if given the chance to acquire proton beam therapy, proton beam machine by your health ministry, would you rather ask for 10 Linacs? I think that's it.
Okay, look, so there's a very easy answer, which is the health technology assessment. And when we did this in Britain, we discovered that there was a very small number of people who got real clinical benefit from protons. And they were quite rare diseases, often in children, such that I was allowed, because I do pediatric radiation, to transfer patients from Bristol to my colleague in America to have them treated. And we would send the planning over and then bring them back and look after them. Now, this means that for a country like Britain, we probably only need one proton therapy machine for a population of 70 million people. And our cost effectiveness threshold for that, because of young children, was actually raised to around $58,000 per QALY. So the answer is, on the back of an envelope, I would say that for a medium-sized middle-income country, the answer is I'd rather have the 10 Linacs. But I might have 9 Linacs and an HDR machine. I met the Chief Health Minister for Bangladesh, who decided that the high rate of cervix cancer meant that a high therapy machine to displace people from inpatient care was crucial, because you need brachytherapy to cure cervix cancer. So you've got to make a decision. It might be, of course, that between FARO, between you all, there will be enough patients who can only be cured by proton therapy. Now remember, if a proton therapy treatment costs, say, $200,000, it had better give you a lot of QALYs payback. It's very simple. If it's $200,000 and your threshold is $10,000 per QALY, it's got to add 20 years of good quality life. And it tells you probably you'll be concentrating then on young patients with curable disease who would otherwise die without it. What I'm aware of, for example, in skull-based meningiomas and many of those tumors for which protons are advocated, is that in fact advanced photon planning can be almost as good, and that for studies in, for example, things like prostate cancer, the initial physical benefit of photon therapy that should have made it better was somehow defeated by the radiation biology. So the answer is you need trials. Probably the economics will add up that you need a proton center in between you, in the middle-income, middle-sized Asian countries. but probably my guess is 9-Linacs and then HDR, please.
I mean, I think I'll choose the Linux rather than Proton,
I
at
can
least
tell you-
for Malaysia anyway. Yeah.
Think about the chest wall, because protons for chest wall breast radiotherapy make a lot of physics sense, but you've seen that the cost per QALY compared to IMRT was $150,000, and therefore was completely outside their range of affordability.
Okay, we have some questions in the Q&A sections. I don't know whether the panelists can see that. I think question one was like quantity or quantitative or qualitative value, but I think that person answered, and then after Paul's lecture, then figured out, yes, it's truly quality and quantity, because I think it's a bit of both. And then there's a question, is there a well-accepted mathematical model to calculate cost benefit? We most often encounter question, is there any costly treatment here or abroad? I don't know, any of the panelists or even Paul. I suppose that's the mathematics that you did just now in terms of QALY, right? So we be saying that maybe we should follow that model.
Patients always ask the sensible question. When you say, I'm afraid we can't cure your cancer, they go, could it be cured anywhere else? Because life is precious. And then, of course, you have to be very realistic, and particularly in children's cancer, where you've often given them first, second, third, fourth line therapy, and they keep seeming to respond. The point of say no can be very difficult. And I promise you, we won't always get this right. But value-based medicine tells you how to explain that any benefit from treatment that is marginal would be overcome by the severe toxicity in trying to deliver it. And that's why value-based medicine can help in all the most difficult discussions. None of those discussions are easy. I promise you we get them wrong. Every grey-haired oncologist has had a discussion that's gone horribly wrong, and it never works out. But to me, it's the best way out. It's to explain what are our aims. And I think that's why it's very important that we decide what is the minimum benefit for which treatment would be worthwhile. Breast cancer patients in Britain said, plus or minus 3% is neither here nor there. They wouldn't consider that a difference. And I think, there's been a lot of work trying to discover what it should be. The WHO Essential Medicines says it's got to make a significant durable benefit in terms of long-term outcomes. So, by which we mean at least 1 in 20 people, 5% absolute survival benefit before it gets considered as an essential medicine. But of course, the essential drugs list isn't the essential radiation therapy list. What we may have to do for FARO is to say, well, for middle-income Asia, what would be the essential treatments that we should deliver, that we know deliver significant long-term benefits, that we believe are the core procedures that should be available in the 8 new centers in Bangladesh, for example, and then build our work around that. So that's a good starting point.
Okay, if we go down the list, there's a I think it's more of a comment here from the same person. I asked my teachers humbly make a guideline for us in the Faro region, as we have different economic conditions in this part of the world. Yes, I think it's one of the things that we've discussed, like in Faro, that yes, we've talked about maybe developing guidelines for this region. But now, interestingly, although we are all Asia, again, there's quite a variation from country to country, and we are fully aware of this. And I think it's something that we need to look into in the future. Like perhaps certain guidelines may be more adoptable for certain parts of Asia, so on and so forth. That's something that I think we will be looking towards in the future, working together to have sort of regional guidelines similar to the European guidelines, or even like NCCN guidelines for the North America. There's a question by, I think, from Indonesia. In view of radiation oncologists, you are proposing hypofractionation, while justification or indication for a change in this method of radiotherapy fraction should be with molecular information in biopsy or blood at the end. There is in addition to targeted drug therapy. So I think isn't unfair while radiotherapy is summed up and cost for more specific diagnostic tools? Well, this is quite a lengthy question. Can the panelists see this question?
Yeah, can I just tackle that first? Because I think it's
Yeah.
a very, and I pointed out the trouble with a long-term trial and a long-term outcome is the standard of care can be suddenly changed whilst you're in mid-trial. And true, we've been working on predictive factors for radiotherapy since I was a boy, basically. And it's true, we try and cherry pick who will do better and who will do better. And it's not always clear, and you have to work with what you've got. So for example, if you can't expand your fractions by 30% in 9 years, as Malaysia needs, we have to shrink our use by 30%, in which case moderate hypofractionation, as performed in Scandinavia and Canada, might be worth looking at. And therefore, for example, when we go to the budget holders and say, we need 30% more LINAC staff, physicists, planning systems to cope in the next 9 years, we need the money for it. The alternative is, however, and you have to make the plans. And you know, what's interesting is COVID has forced many of us to decide what is acceptable treatment today. You know, when you have to run your department with physical and time gaps between patients and you're giving less fractions, you'll see that the work of the British Royal College of Radiologists has been to produce a website of acceptable hypofractionation regimens that we could use. And what I think is interesting is that might make a very good starter for FARO guidelines, because you say, look, is there a floor below which we won't recommend? So would you recommend 5 to 7 fractions of prostate radiotherapy if you don't have full 3D IMRT? And the answer is absolutely not. But what about more conventional treatments? The answer is, well, maybe. So I think COVID is forcing us in many ways to look, you know, centers that were giving a year of trastuzumab might now decide that having patients come in and out of hospital that are full of COVID patients is a bad idea. And that actually, when you look at the MRC study of 9 to 12 weeks of trastuzumab versus 1 year, whilst the outcomes are slightly worse for 9 to 12 weeks, the QALYs are higher for the short course treatment because you avoid a lot of toxicity and time in hospital. So I think COVID is a very interesting time, and it will force all this onto the agenda because, you know, look in Britain at how many people haven't been diagnosed with cancer this year. Cancer won't go away. They're going to present next year with advanced cancer, and they will need more radiation therapy. So I think this whole discussion we've had today, instead of being a leisurely 10-year budget planning device for building proton centers across Asia, could turn out to be a scramble to avoid cost cutting and disasters in our centers literally within a year.
Thank you, Paul. The next question was, for those interested in VBM, how do junior colleagues get engaged into this field? Are there part-time courses that someone can actually attend? I don't know, Paul, is there any sort of like maybe virtual courses now, VBM, that you know of on a regular basis?
So we've started to put these online. We've built this as part of management studies into the core training for radiation oncologists in Britain. So I think it's one of those things that, you know, traditionally the radiation oncology syllabus comes from the Atomic Energy Authority in Vienna and is focused very much on radiation biology, statistics, physics, those sorts of things. But I think we need to, as we adapt that, realize that we will need a lot of leadership and advocacy skills, and for that we will need the language and science that has been adopted for health technology assessment elsewhere. And I think my prediction is that when we finally meet up for the next exam committee and we talk with the dean of the university, we have to start thinking, when will we bring in the lecturers in economics and business planning to teach this to our trainees? Or do we select a few high flyers each year and send them on a specific FARO course? There are lots of ways around it. And of course, the answer is that there's not going to be one right solution for each country. For a large country, you know, maybe you can do it internally. What we should do is to start assembling the resources. Remember that best is the enemy of good. You know, just because you can't do 7 fraction stereotactic body surgery doesn't mean that you can't do 2.5 gray fractions with a bit of IMRT, and so on. So I think we have to start somewhere. The value-based medicine course at the National Cancer Institute in Malaysia started with 3 of us meeting in a coffee shop. These things tend to start small and grow. And so don't be put off. In Malaysia, 5 years ago, we were at ground level. And look at where we are now. We get 200 or 300 people at our meetings. And last time we had the surgeons along to explain how they use the same principles to decide between day case and in-hospital care. And almost the best speaker was the surgeon, who we realized was already well ahead of us, the hernia repair expert from Malaysia. So we should be humbled by the skills of others, and we should be clever enough to work together.
So I guess, I mean, it's quite possible that if, I mean, it looks like COVID is actually going to be a prolonged thing, that it's quite possible that we may, in fact, conduct the next course in IKN like virtually, for example, right? I think that's something that we can actually, you know, work for, I suppose, going forwards, because I don't know, like, I don't know when this is going to settle, but if ever we do actually hold a virtual course in VBM, I mean, certainly we would actually open it up to FARO member countries.
I would like to add a bit of comment on the hypofractionation. I think this is one of the way forward in the immediate short to medium term, because it depends what style you are advocating. If you follow the American-based treatment, they tend to be quite prolonged radiation courses and still 2 grays per fraction. While if you follow more of UK or European style, then they do a lot more hypofractionation. And it's interesting, even things where the resources are very tight, let's say for HDR brachytherapy, some are still trying to follow the ABS and the American Brachy Society. They want 5 fractions. I mean, then there is a long waiting period, and I was somewhere, and they said that, oh, there's a long waiting list. The patient finishes the radiotherapy, and then they have the brachytherapy like 1.5 months later. What's the point of that? So when I say that, why don't you just do 2 fractions, and they look at me in horror. So but this is fairly acceptable, and what is completely unacceptable. So we can draw a line. Maybe 2 fractions is okay, but 1 single fraction is crazy. Something like that.
Thank you for your comments, Fuad. So any comments from Tati or Farouk? Or
Can I add something, Anita?
yeah, sure, please.
We do also some calculation about the need of radiotherapy equipment in our countries. How to close the gap. And when we use the calculation using the hypofractionation, as well as when we extend the working hours using the 2 shifts of RTTs, so we will get the lower number than we use the normal fractionation, because we have an average of fractionation within the countries. It is 25.25, and if we reduce the fractionation number to 20, so the number that equipment that we need in our countries is become lower. So that's maybe a good idea if we want to do the cost-effective analysis of the number of equipment that we need in our countries. Another thing that we do in our countries is we try to see, that cervical cancer is still the high number in our low middle income countries. The treatment of choice for the locally advanced is chemoirradiation. So we do the survey to see the patient perceived utilization of the patient, what they need, and we get that.
But you want to share your slides? I think you have something on this, isn't it? That'll be interesting to share your experience. Yeah.
Sorry.
Just just a few slides that I had prepared for this purpose. I think it's be very useful to share with us.
Can you see my slide?
Yes, Tati. Thank you.
So, moment. What we do here is we do some analysis using the assessment of utility value of each group, and how is the cost effective of this analysis. And we can see here, we do a questionnaire assessment of the utility value, and we compare the RT with the chemo RT. And we can see here that the utility value score is better in the RT only. And then, interesting, when we do we got the survival from the literature, from the publication, 3 to 4 years, 3 years for the RT and chemo RT 4 years, and we can see is that the quality value is not different too much. It's only 2.55 and 0.88. So then when we use cost per collie, so we do calculation how many money that we need for radiation and for chemoradiation, and we divide it with the level of collie. We can see here that the cost per collie for radiation is better than cost per collie for chemoirradiation. So I just want to see here, using the value-based medicine, even the evidence-based should mention that the chemorad will get a better treatment result. But if we take into account the patient perceive or utility from the patient, so it will can be seen that the irradiation can be better. Then since that, that for the low and middle income countries, so we have still no cost-effective threshold. So we use the cost-effective threshold or willingness to pay 1 to 3, as you mentioned, from the GDP. Even if we use that threshold, both of the modality seems still inside the cost-effective within the countries. So that's maybe just a simple things that we can do. I just want to say that we can see that even evidence-based mentioned that chemoirradiation is better for the locally advanced cervical cancer. But if we take into account the patient perceived or utility of the patient, so it will become looks like that radiation is not inferior compared to the chemoirradiation. Yeah, thank you.
Thank you, Tati. That's very useful sharing there. Now, just a couple more questions to go through. Is there a proposal by FARO about the research in expenses and radiation treatment by the contributing countries? Well, so here we are today. So it seems that I think after today, we may have to look into this. We actually have a research committee under FARO. I'm not sure if the chair of the research committee is actually here with us today. But certainly Shyam, who's the president. Shyam, do you want to make some comments? Maybe this is something that FARO can actually do in the future in terms of research. Shyam is there. I can see his name, but he's probably gone offline for a bit. But but it's something that that's Shyam is. Whether or not FARO will be doing research, to look into all this cost and value.
Yeah, Anita, thank you very much. Actually, I'm traveling. I'm in the car, so the
okay.
All right. Maybe Dr. Tamaki can
okay. Okay, Tomo, please. Yeah. Some comments from Tomo.
Well, I think after today's lecture, we can initiate our discussion about how to do the research and incorporate the value-based medicine in, at least in our thinking of research. Of course, the challenge in our part would be that we have a diverse group of countries within FARO. From country from a higher income to comparatively lower income. So we could set up some of the model where each country can adapt to their own national circumstances probably. But I think that could be an interesting approach. I would like to ask for the opinions from Paul, Dr. Korn.
Well, can I tell you, nowhere is more diverse than Europe. We have 31 countries, and you've seen that we can, in colorectal cancer, the spend per patient varies 22-fold across those 31 nations. And it's led us to look at patients, how we manage them in pathways. So we're looking at the cost of each step and which order you go through and what's the right treatment. And why is this important? Well, when the European government looked at the sustainability of healthcare across 28 European nations, they discovered that only 2 were probably sustainable long-term to the future. And that was Britain and Sweden, because they explicitly only fund new spending on the back of a health technology assessment. So what I suspect is that every country differs, but the technique of thinking about value-based medicine is the key, which is why it's been the key policy pushed by the World Health Organization, because they say, look, you can all do your own things, but this is the kind of metric that you'll be needing. This is how you need to make your decisions. I showed you how you could choose to spend your new budget in a way that hopefully was open and fair. You know, if you didn't get any cancer drugs, it was explicit why. So I wouldn't be worried by the diversity. I mean, a QALY is a QALY is a QALY. I think there's lots of studies. If one country has looked at the cost effectiveness of a moderately hypofractionated regimen from their point of view, then as long as the model is clear, you know, how many staff hours you need to deliver treatment A versus treatment B, for example, then you can adapt that work. And it is easier to adapt an HTA that's already been done than start from scratch. So in Malaysia, we had an agreement with the Ministry of Health that if an HTA from somewhere else showed that the cost of treatment was going to be more than a couple of times the per capita income per year, we would just let it ride. We go back to the maker of the drug or whatever and say, come back when you can make it. It was less than one, we would demand a full HTA, and the Malaysian government agreed to fund that. In the area between the 1 and 2, we had to make a case. So basically, by reading other people's HTA, you could rapidly sort them into highly affordable, get on with planning for it, possibly affordable, needs an HTA from the Malaysian, Indonesian, Indian perspective, and then the go away, tell the company to come back with a cheaper proton machine, a cheaper planning system. And that approach is based around the same core data. But we do need validated outcomes. We want to know where we start from. Remember, all these decisions start from where you are now. And so we need to know not only what the outcome for patients in Bangladesh are, which we now know for advanced cervix cancer, in terms of ALIs, what's the lifetime, but in terms of the QALY. So what I'd say is, there's a few steps we need to get straight away. We need to start asking questions and recording them in a way that turns our notes into meaningful data. What I discovered, someone's mentioned the American brachytherapy and the JEC-Estro HDR brachytherapy system, which came in, which asked for incredibly high doses of brachytherapy. And what we discovered was that no one was publishing any results after that, because of course they were all finding it inferior. So when I met, I don't know if Fenny's online, but you sit in a coffee shop and go, how many of your patients make the ABS target dose? And the answer is almost none of them, because the rectal dose and the bladder dose is so high, we pull back. So we discovered that there was this sort of envy. Oh, the Americans and Europeans have set this thing. We can't possibly hope to meet it. Let's stop there. And the answer was, actually, most of our patients didn't make it, but we still got very good outcomes despite that. And that's, of course, why 2 or 3 fractions can do well, because the final 2 fractions of the 5-fraction system often can never be delivered. But to discover that, we had to plan everyone with 3D planning. So we do 3D planning for cervix cancer. We fuse MRI and CT pictures to do it. And that's what you need to deliver it. So if you're doing 2 to 3 fraction HDR without MR-CT fusion, don't feel ashamed, publish your data and share how you did it. But report the data in QALYs. That's the crucial thing.
Okay, I think we just make room for just one last question in the Q&A box, because I think this is perhaps quite a pertinent question. It says here, thank you for the insightful presentation, Paul. This is from Septiara Putri. Sometimes we face the dilemma about the economic evaluation of health technology, which indicates the good value for money. However, in terms of affordability, there remains substantial budget required on the system. How to deal with this issue in terms of providing input for decision maker?
Okay, so the answer is very simple. We need to decide what a core treatment is, and medical oncology has been very sensible. They have an agreed system with the WHO each year to decide what are the core essential medicines, which by definition should be made available free or at affordable prices that families can afford. Now, what we need is something similar, and the Lancet Commission from Radiotherapy actually started to make a very good call on that. And in fact, radiation oncology is very cost effective. If we could skill up and equipment up everyone to the standards of Europe 10 years ago, we would save millions of life years. And in fact, that investment would be cost saving in the long run. As you've heard from Indonesia with Prof. Tati, that better treatments in the short term don't have much quality gain, but the long term can pay back a lot. So we need to have enough of us to go to our funding authorities, our governments, and go, this is good value. But as I started with, the problem with radiation oncology is we need a huge upfront budget, and few health systems can afford that. What they have to do is put aside ring-fenced money every year to build the next center. And of course, the World Bank has agreed to finance them on the basis that it's put in with value-based medicine, which is probably how Bangladesh has got their 8 new centers as part of the World Bank program. So across FARO, we have to identify successful approaches, where they've worked. What was it that made a successful bid? In Brunei, they've got so much money, they can have what they want. But for the rest of us, we have to demonstrate that spending on cancer medicine is better than spending on rheumatology, better than spending on the education budget and the police budget. And that means, unfortunately, and for that, working together has to be a really smart move.
Thank you, Paul. Now, just the final comment from any of the panelists. We are coming up to almost 2 hours, and I'm quite surprised. This, Friday evening in Malaysia, at least anyway, value-based medicine, health economics, and we still have about close to 260 people in this webinar. So, any last comments from any of the panelists?
I suppose the fact that we cannot go anywhere has helped to keep everybody here.
Okay, Farouk.
Yes, I have last comment, because we have to formulate the budget properly, allocate resource allocation very smartly, and spending wisely. That is the key issue of very cost-effective management in healthcare system, particularly in cancer care through radiotherapy. Thank you very much.
Thank you, Farouk. Tati?
I just want to ask Paul a very smart, short question, very short question. So when we want to decide a strategy of treatment, do we need to do cost-effective analysis but each treatment, or how is it? Otherwise, it will become a very big work, right? As I did for the chemo and chemo-RT in locally advanced cervical cancer. Do we need also to do it for the others, or what? What do you think? How is the implementation, the real implementation of the value-based medicine? Thank you.
So that's a fabulous question. It's a good one to finish on, because what you don't want to do is then to go away thinking, oh, there's years of work to be done. So look, cancer is 200 different diseases with which we give the umbrella name cancer.
Yeah.
In any one country, about 10 to 12 tumors will dominate 90% of the cancer incidence.
Yes.
And we believe that guidelines need to be redrawn about every 2 years.
Yeah.
So in Malaysia, when 3 of us sat in the coffee shop and said, oh my goodness, what have we done? We realized that in fact, what we needed in year 1 was about 5 to 6 value-based guidelines. In year 2, about 5 to 6 value-based guidelines. And then we needed to renew them in a similar way. So we realized it would take a fair bit of work. Now, if it took, say, 5 or 6 people to draw up guidelines, what it means is out of the 100 radiation oncologists, we need to borrow a few of them for a few weekends and evenings work to create the sort of value-based guidelines that we want. And we said to everyone, best is the enemy of good. We start very simply with just useful statements. The following would be acceptable doses, fractionations, and techniques, because that, in a way, sets the floor at what we're doing. If you can't manage that in your center, then it enabled you to go to the ministry and say, we really need more help. And they might say you're wasting money elsewhere, and you could have that dialogue. So don't be frightened. You cannot have a guideline, although NCCN tries for every single case. You end up with documents that are too unwieldy, and breast cancer radiotherapy, which, remember, cures people. Nodal radiation for 10 or more positive nodes has an impact as great as chemotherapy on long-term survival benefits, is down to 1 page. and that's not right. So we've got to realize the value that we can give and drop treatments of no value, promote those that are, and work together. And it sounds like a big piece of work, but I promise you, once you've started, it should be simple. So just to finish off, not long ago, I read a paper from India, because having done some of my training there, I read the journals and I give lectures there on a regular basis. So I read a paper that said, we've read the American guidelines on colorectal cancer, and they may not be appropriate for a low and middle income country, and therefore we've written our own. So I read through, and their committee sat and endorsed every single policy of the NCCN guidelines. Now, the challenge for India is that in India, we've introduced a national service that will guarantee a floor on funding each year for healthcare. So here's one of the real challenges for us to think about. If we were in India as a radiation oncologist or a medical oncologist, what treatments would we recommend that come within that price level set by the insurers? So what could we do with what we have? And it's not NCCN, and it won't even be Astro, but between us, we might find, as I say, useful things. I had never learned that you could give maintenance oral chemotherapy that has antivascular effects that's as effective as bevacizumab in head and neck cancer. Thank you for Tata Memorial Hospital for that study. I hadn't realized that 4 fractions 2 days could give such a degree of palliation and shrinkage to very large head and neck cancers until I saw it with my own eyes. But that won't get you a paper in the Red Journal, but it should get us a place on the next FARO webinar. So we want people to start coming forward and going, we do have treatments that aren't American standard, but are very useful. And here is our data. And that could be a great start.
Thank you very much, Paul. So I think we're coming towards the end of our session. So thank you very much, everyone. I think we all deserve a round of applause. So let's have a clap. Yeah.
Mayang, is there no photo session?
Yes.
And of course, thank you for the participants for staying on with us until this late. So, you know,
Yes,
very
please
thankful.
ask your husbands and wives to forgive you. Remember, the quality advantage of marriage is so great that I didn't want you to go home and face an argument.
Okay, so we are on for a photo session now, is it, Tati? Oh.
Yes, I think Nico, Maya.
Yes.
Yes. Do a
Please,
photo
Prof.
session, everyone.
Dr. Nico will, yeah. Okay, thank you, Nico.
Yes. I will take picture in 3, 2, 1.
Admin 2, please, video on. The admin 2, who is the admin 2? Yeah.
Okay. Maybe one more time, please hold your position for 3 seconds. Okay, 3, 2, 1. Okay, thank you very much.
Thank you very much, everyone. And Paul, you don't have any objections if we actually upload this recording and your presentation onto...
Remember, we want to be of value. If you think it's useful, and we
Yes.
covered it in a short time.
Thank you. Thank you. So we'll do that, and we will notify those who are interested to look at the recording. Bye now, everyone. Thank you so much.
All the best, and have a nice weekend.
Stay safe.
Stay safe. Bye.
Bye.
Bye, Miriam.
Have a nice day.
How are you?